Okay, we want to talk a little bit about venous return and circulatory shock. We're going to explain how blood in the veins is returned to the heart. And we'll discuss the importance of physical activity in venous return and discuss several causes of circulatory shock and name and describe the stages of shock. So venous return is the flow of blood back to the heart, and it relies on a pressure gradient. Blood pressure is the most important force in venous return. About 10 millimeters of mercury venous pressure toward the heart is what's required. Gravity drains blood from the head and neck, and the skeletal muscle pump drives it in the limbs, and that's basically the action of your skeletal muscle squeezing and relaxing around the lumen of the vessel, and that forces in the veins the movement of blood through those one-way valves and eventually back to the heart. The thoracic or respiratory pump is driven by your inhalation. The thoracic cavity expands and thoracic pressure decreases and abdominal pressure increases, and this forces the blood upwards back towards the heart. The blood flows faster with an increased inhalation rate. And there's also cardiac suction of the expanding atrial space. So there's a little bit of draw as the heart actually pumps. And what we're looking at here is the actual skeletal muscle pump, and you can see how as the skeletal muscle contracts and relaxes, that produces an upward pressure against the pull of gravity back towards the heart, and you can see how the blood is driven through these one-way valves. And eventually, if we're talking about the lower limbs, we're going to reach the inferior vena cava and re-enter the right atrium. Now, occasionally what will happen is that these valves will become distended and weak, and the blood will pool in the lower extremities, and that produces a condition called varicose veins. And aside from being unattractive, it's also it's a health risk, because this slows the flow of blood, and when blood flow slows down, blood can spontaneously clot. And if you have spontaneous clotting of the blood, you can produce an embolus, and an embolus can easily become lodged in a capillary bed that supplies either the heart muscle or the brain. Just two examples. In the brain, this could cause a stroke, and in the heart, this could cause a myocardial infarction. Remember that brain tissue and heart tissue doesn't regenerate after injury or death, and as a result, the heart is permanently weakened after an event like this, and the brain permanently loses that tissue as well. So this is a dangerous situation. These veins can be surgically removed. They use laser surgery and also just standard surgery to resect these vessels, and the body has an amazing ability to regrow a lot of blood vessels, and as a result, it's not like you permanently lose that capacity. It's just that we don't want to run the risk of producing emboli. Okay, exercise increases venous return in a lot of different ways. The heart beats faster and harder and increases cardiac output and blood pressure. The vessels of the skeletal muscles, lungs, and heart dilate and they increase flow, and the increased respiratory rate, thoracic pump action, and skeletal muscle pump action also increase venous return. And we like that. As we increase venous return, what we do is we are going to increase cardiac output because we're going to increase stroke volume. Venous pooling can occur in many different ways. This usually is accompanied by inactivity. With prolonged standing, cardiac output may be low enough to cause dizziness, and this is prevented by tensing the leg muscles, and this activates the skeletal muscle pump, and this is one of the reasons why jet pilots wear pressure suits. So obviously we want to get enough blood to the brain to keep us conscious. This is one of the reasons why in the military you're told if you're standing at attention that you don't want to stand perfectly stock still, because you won't be able to get enough blood back to the brain to retain consciousness. And so they tell you to tense and relax the leg muscles so that you can keep blood heading back to the brain. Okay, we want to examine some special circulatory routes as well. We'll explain how the brain maintains stable perfusion, and we'll discuss the causes and effects of strokes and transient ischemic attacks. And we'll explain the mechanisms that increase muscular perfusion during exercise. We'll contrast the blood pressure of the pulmonary circuit with that of the systemic, and we'll explain why the difference is important in pulmonary function. So total blood flow to the brain fluctuates less than that of any other organ. Seconds of deprivation can cause loss of consciousness. 4 to 5 minutes produces irreversible brain damage. Blood flow can be shifted from one active brain region to another, and the brain has a lot of circuitous routes to make certain that it remains perfused as much as possible. We're going to examine some of those routes. The brain regulates its own blood flow to match changes in blood pressure and chemistry. Cerebral arteries dilate as the systemic blood pressure drops, and they constrict as the blood pressure rises. Now think about why this makes sense. If we didn't do this, if we didn't keep the blood pressure in the brain at a constant level, at an optimal level, it could rise to the point where you could burst capillary beds, and that could produce a stroke, or it could drop to the point where you lose consciousness and brain cells die due to lack of perfusion. So we have a self-correcting mechanism to keep the blood flow to the brain constant and the pressure in those vessels constant. The main chemical stimulus is pH. Hypercapnia occurs when CO2 levels increase. This results in the pH decreasing, and this triggers vasodilation. Now, you're going to have to think back to why the pH decreases as CO2 levels go up. Remember that as CO2 is introduced into an aqueous solution, it'll associate with water, that will produce carbonic acid, and carbonic acid can spontaneously dissociate into bicarbonate, anion, and free protons. And it's the free protons that produce the drop in pH. And so we don't want the pH to get too low, because what will happen is that eventually metabolic processes will cease, and in addition, membrane potential will be altered. Remember that protons have a positive charge, and as a result they can affect where cations and anions find themselves, and this will affect membrane potential. On the other side, when we're talking about enzymes that trigger reactions that keep life processes going, we're looking at denaturation of protein, and if enough proteins denature, then metabolic processes will stop and the cell will die. So again, this is why we need to keep pH within a nice tight limit. Hypocapnia raises pH and stimulates vasoconstriction. Think about what's happening here. Let's look at hypercapnia. CO2 levels go up, pH decreases, so what happens? We have vasodilation. Now you might think, well, how in the heck does this get our pH back to normal? Well, what's happening really has a lot more to do with what's going on at the lungs than what's going on at the brain. The vasodilation causes an increase in the perfusion of the lungs with deoxygenated blood. The other thing that's happening that we don't really address at this point is that your respiratory rate goes up. So you blow off more CO2, and the net effect is eventually to bring pH levels back within normal limits towards neutral. So what will happen after a little bit of hyperventilation and vasodilation is the pH will eventually rise back to neutral pH. In hypocapnia, this raises the pH and stimulates vasoconstriction. It can occur with hyperventilation. It can lead to ischemia, dizziness, and sometimes syncope. So what they're talking about here is what can trigger hypocapnia. So if you think about it, if you hyperventilate beyond the point where we restore normal pH, what happens now is that you're removing CO2 from tissue fluid and from blood plasma quicker than you're creating it, and the net effect then is to cause the pH to elevate above optimal, and what will then happen is that you can have ischemia and dizziness and syncope. Transient ischemic attacks are brief episodes of cerebral ischemia, and they're caused by spasms of diseased cerebral arteries. The dizziness, loss of vision, weakness, paralysis, headache, or aphasia can be symptoms that go hand in hand with these spells. Aphasia is a difficulty speaking. Weakness, paralysis, and headache are understood. This is usually a short-term situation. It's often called a mini-stroke. And it's often an early warning sign of an impending full-blown stroke. A cerebrovascular accident or full-blown stroke is the sudden death of brain tissue caused by ischemia. Contributing factors include arteriosclerosis, thrombosis, or ruptured aneurysm, and the effects range from unnoticeable to fatal. Some outcomes: blindness, paralysis, loss of sensation, and loss of speech are common. Recovery depends on the surrounding neurons and the collateral circulation. Very often, if it's death of brain tissue, in some cases, individuals can relearn the skills that were lost as a result of a stroke, but that isn't because the brain tissue regrows. It's because the brain learns how to perform those activities using different neural circuits than the ones that were present prior to the stroke. And so you've probably read stories of people that have to relearn how to walk and talk after a stroke, and this is a property of the nervous system called plasticity, and it's one of the upsides to having a whole lot of extra nervous tissue in the central nervous system. We don't regrow any of it, but you could think of the brain and the spinal cord as having a deep bench, so that if you have a mild bit of damage, it's possible to use the excess capacity to reestablish connections that would allow you to perform the activities that you lost the ability to perform prior to the accident. Now, it's not in all cases, it's just in some. Okay, skeletal muscles are highly variable flow depending on their state of exertion. Remember that skeletal muscle, because of what it does, it contracts and relaxes, and as a result uses lots of ATP, requires an extremely adequate blood supply. Right? At rest, what happens is the arterioles constrict and the most of the capillary beds will shut down, and that's because we don't need as much blood per unit time when the muscles are at rest. But during exercise, the arterioles dilate in response to epinephrine and sympathetic nerves. Remember that the sympathetic division of the autonomic nervous system is your freak-out division, and it's not a surprise then that under the influence of the sympathetic division of the autonomic nervous system that you would see dilation of the arterioles, because the idea is to deliver more blood to the skeletal muscle per unit time so that you can carry out your activity. You can engage in the fight or flight response. Precapillary sphincters dilate due to muscle metabolites such as lactate and carbon dioxide. Let's talk a little bit about the lungs. A low pulmonary pressure is found in the lungs. This is usually between 25 and 10 millimeters of mercury. The flow is slower. This allows more time for gas exchange, and it's engaged in capillary fluid absorption. Oncotic pressure usually overrides the hydrostatic pressure in this case, and it prevents fluid accumulation in the alveolar wall and the lumen. This would lead to a condition like pneumonia if it were allowed to persist for a long period of time under high pressure. In fact, what we see in certain types of heart failure is an accumulation of fluid in the lungs, and that makes it extremely difficult to effect gas exchange, because what you've done is you've introduced an extra layer that the gas has to go through, and as a result the exchange of oxygen for CO2 becomes much less efficient. That's true for any interfering layer that you introduce in the lungs, whether it be fluid as a result of this type of phenomenon, or whether it be tar as a result of cigarette smoking, or particulates, or asbestos, or in the case of cystic fibrosis, extremely thick mucus that's been colonized by bacteria. There are unique responses in the lungs to hypoxia. Pulmonary arteries constrict in a diseased area, and this redirects the flow to a better ventilation region. And this is an example of what we call perfusion ventilation coupling. The lungs are, we won't say clever, but adaptive, in that remember that the blood that perfuses the lungs and the oxygen, the air that enters the lungs from the conducting division, is all under the control of smooth muscle. In the case of the blood, the smooth muscle that's in the arterioles and venules, the capillaries, and in the conducting division, it's under smooth muscle control in the bronchioles. And so, as a result of autonomic innervation and the response to hypoxia, the lung will always direct ventilation to the area of the lung that's most well perfused with blood, and also direct blood to the area of the lung that's most well ventilated by the air that's coming from the conducting division. So this makes maximal use of the viable surface area in the lungs that's available for gas exchange. Okay, we'll look at the anatomy of the pulmonary circuit and trace the route of blood through it. And here you can see the pulmonary circuit. The pulmonary trunk leaves the right ventricle and it heads via the pulmonary arteries to the lungs. Now, remember that in the pulmonary circuit, the arteries contain deoxygenated blood and the veins contain oxygenated blood. This is the reverse of the systemic circuit. The reason for this is that let's call it the exhausted blood, the blood that's full of CO2 and generally nutrient poor, arrives back at the right atrium. The right atrium will then squeeze and thrust blood through the tricuspid valve into the right ventricle, which will then squeeze and thrust blood through the pulmonary semilunar valve into the pulmonary trunk right here. At the same time, that back pressure will force the tricuspid valve shut so that there's no reverse flow of blood backwards through the heart. The blood will then go from the pulmonary trunk into the pulmonary arteries here and here, and each pulmonary artery will then branch into a lobar artery. So here you can see the right pulmonary artery branching into a superior, middle, and inferior lobar artery, supplying these lobes of the lungs. Remember, there's 3 lobes on the right lung and 2 in the left. And then on the other side, this left pulmonary artery will branch into a superior and inferior lobar artery. And once we're in the lungs, what happens is the magic of gas exchange. Remember, this is the respiratory division of the respiratory system. This is where we actually swap CO2 for oxygen. And so if we look here at sort of a blow-up of the pulmonary circuit, this is where the terminal bronchioles end and the alveolar sacs receive the air that's coming from the conducting division. And notice that we're surrounded on all sides by capillary beds, and the layers are extremely thin here. You've got 1 cell layer thick for the alveoli, and the capillary beds are likewise equally thin. So you only have to go through a couple of cell layers and a very, very thin layer of fluid. This is the surfactant that lines the inside of the lungs to get to the blood. And so this is good because the concentration gradient between the alveolar air and the deoxygenated blood that's coming from the heart drives the oxygen into the blood, and at the same time that concentration gradient is reversed for carbon dioxide, and so carbon dioxide will diffuse out of the deoxygenated blood into the alveolar air, and then we'll blow off the CO2. And so what happens is that the blood will change color from a dark red in the veins to a bright red, indicating that it's bound to oxygen. And what's going to happen next is we're going to return back to the heart. So if we look at the systemic circulation, this is what happens once the oxygenated blood returns to the left atrium and enters the left ventricle for its trip into the aorta. So we'll ID the principal systemic arteries and veins, and here you can see an overview. There's a lot of stuff in one picture. What we're going to do is break this down so that you can see some of the major branches. So this is the systemic circulation. This is the oxygenated blood that's in the systemic arteries, and this is what supplies the entire body with the oxygen needed to perform cellular respiration. Remember that the need for cellular respiration is predicated on the fact that in the presence of oxygen, the cell can extract between 36 and 38 ATP per glucose molecule, whereas without oxygen, in the anaerobic situation, you could only extract a whopping 2 ATP per glucose molecule. So in order to pay the body's energy debt, we have to have oxygen present so that we can produce enough ATP to run this entire machine. And so here we're looking at the aorta and its major branches. So this is the anterior view of the heart. There's the superior and inferior vena cava, and that's the right atrium. The left, or the right ventricle will be right about here. And then this little branch, this little collection of fat, basically runs down the exterior of the heart where the interventricular septa appear. And so the left ventricle is the most muscular chamber of the 4 chambers of the heart, as you remember from our chapter on the heart. And what happens when the left ventricle squeezes is that the bicuspid valve between the left atrium and the left ventricle will slap shut. At the same time, the aortic semilunar valve will open and blood will enter the ascending aorta. And right off the ascending aorta, you have the brachiocephalic trunk. Now, think about the name for that vessel, brachiocephalic. So where do you think that vessel ultimately goes, right? Cephalic means of or pertaining to the head or the brain, and brachio means of or pertaining to the arm, all right? So it's not a surprise that this branches into the right common carotid artery and the right subclavian. The right subclavian artery, again, look at the name, subclavian, meaning what? Under the clavicle, okay? So this is going to run under the clavicle, and eventually that's going to become the brachial artery, as we're going to see as we branch out. Right common carotid heads up to the brain. So the brain gets an immediate supply of blood straight off the aorta of the heart. And this is important because the brain is vital to keeping us alive. So it gets, right after the heart, first dibs on the oxygenated blood supply. As we move on through the aortic arch, this is the aortic arch, right? We see the left common carotid and this left subclavian artery. Left subclavian artery is going to break under the left clavicle, and the left common carotid artery is going to head up to the left side of the brain. Then we move down the descending aorta and through the diaphragm, all right, and we then become the abdominal aorta once we pass through the diaphragm through the aortic hiatus. Okay, so thoracic aorta behind the heart here, and abdominal aorta as we descend through the diaphragm. So remember that the lungs are on either side in the thoracic cavity, and this whole thing is bound by the bony thorax, which is made up of the sternum, the ribs, and the vertebral column. And this is a nice arrangement because this keeps some of our most vital organs well protected in a bony cage. Now, let's move on. The common carotid artery divides into the internal and external carotids, and the external carotid supplies most of the external head structures. And so what you've got to think here is now we've broken off the aorta, all right, and what you're going to see, if you look, this is the external carotid artery, all right, so this is going to be a more laterally running artery, and then the internal carotid artery, which is more medial, right, and this supplies blood to the brain. Further branches include the superficial temporal artery and the posterior auricular artery and occipital artery, and again they're named for the areas of the brain that they supply. Temporal artery supplies the temporal lobe of the brain, occipital artery the occipital lobe, and the posterior auricular artery is basically a branch of the occipital and supplies more of the occipital lobe as well. Now, as we look at some of the other branches, the carotid sinus is essentially a large open vessel. It's still an artery, and it's off of the carotid sinus that you see these other branches leave. Okay, the vertebral artery runs lateral to the spinal cord and is very closely associated with the vertebral column, supplies blood to the spinal cord and to the associated tissues. The thyrocervical trunk down here is going to supply regions of the neck, that's cervical, And the costocervical trunk also supplies lower areas of the neck near the costal cartilages. And the axillary artery is named for the region that it runs through, which is the axillary region, which is under the arm. Okay, the brachiocephalic trunk we've already discussed, as we have the subclavian and common carotid. Thyroid gland, remember, is located in front of your trachea. It's one of the organs of the endocrine system. The superior thyroid artery runs above the thyroid gland. The lingual artery runs towards the tongue. The facial artery supplies, again, the facial structures, particularly here near the mandibular and zygomatic regions of the skull, and the other branch supplies the mandibular region. Ophthalmic artery, not a surprise, it runs near the orbit. All right, ophthalmic means upper pertaining to the eye, and supraorbital artery runs above the orbit. Okay, supra above, orbital upper pertaining to the orbit. Okay, the paired vertebral arteries combine to form the basilar artery on the pons. Remember that the pons is a component of the brainstem. It lies just above the medulla oblongata and just below the midbrain. The circle of Willis is on the base of the brain, formed from the anastomosis of the basilar and internal carotid arteries. This supplies the brain, the internal ear, and the orbital structures. There's an anterior, middle, and posterior cerebral artery in the circle of Willis, as well as a superior, anterior, and posterior cerebellar artery. Now, what you want to notice here, you can see the circle of Willis right there, is that it's, I don't know if you've ever been driving in a European country or if you've been to cities like New Orleans, but you have these circular roadways called roundabouts, and they have a lot of branches coming off of them, so it's like a super intersection. And the idea with a roundabout is it serves as a major intersection for a lot of roads and streets, and it's always possible to find an alternate route out of the roundabout if one of the other intersecting streets is blocked. And the same is true here in the circle of Willis. What you've got are a lot of branches coming off this circle, but the nice thing about it is that if it's blocked, the blood can route its way around the blockage and still manage to perfuse the entire brain because of these branching arteries and these anastomoses. There's the basilar artery there running right in front of the pons, and there's the circle of Willis right there. So it's a nice arrangement for the brain because the likelihood that you're going to completely cut off blood flow as a result of blocking one of these major arteries is relatively remote. Okay, so you've got connecting arteries here, you've got connecting arteries there, and as a result, it's very easy to keep the brain completely perfused. And this is just showing you a sagittal section through the same area. You can see the anterior cerebral artery right here and the posterior cerebral artery as well. Okay, these are the major systemic veins. Deep veins run parallel to arteries, while superficial veins have many anastomoses. Now, an interesting thing about the veins and the arteries. Generally speaking, with a few exceptions, veins tend to be more superficial than arteries are. And there's a logic behind that, which is that the blood in the veins is under much lower pressure since it's much further from the heart. We're talking here about the systemic venous circulation. So when you injure yourself, you cut a blood vessel, you generally cut a vein. The blood in the veins is under low pressure and it has a very low oxygen content. As a result, if you lose that blood, it's not as valuable to the body as blood that would be contained in the systemic arteries. If you've ever seen an artery nick, you'll never forget it because the blood comes spurting out and in some cases it will hit the ceiling. It's a pretty spectacular thing to observe. Generally, the arteries are much deeper in the body, with the exception of the pulse points. And this is kind of by design, right? Because if you nick an artery, you lose blood under high pressure with a high oxygen content. And so you're in danger of massive hemorrhaging in a very immediate time frame. So bravo for the body's design. The other thing that you want to remember as you look at these major arteries and veins, and also think back to the chapter on the nervous system and the lymphatic system, is that generally the major vessels, the major nerves, the major lymphatics, they tend to follow common routes. Generally, where you find a major nerve, you'll find a major blood vessel and a major lymphatic nearby. You'll usually find an artery and a vein paired. And again, this is design. The idea here is that if you run these, let's call them cables or pipes, along common routes, you're less likely to weaken the body by having to go through structures that give the body sort of a sound foundation. You don't unnecessarily weaken them by running through an excess number of holes or folds or divots or whatever. Again, use the example of somebody putting in a new stove in their kitchen. There's the smart way to do it and the stupid way to do it. The stupid way to do it is to punch one hole in the wall for the electric, one hole in the wall for the exhaust, one hole in the wall for the gas, and then what you've done is you've weakened the wall in 3 spots. Generally what you do is you run a sleeve through the wall at one point, and you run all those major cables or major pipes through a single opening, and that doesn't weaken the wall as much. And the same can be said for the human body, generally speaking. Okay, so here you can see the veins of the head and the neck. There are large, thin-walled dural sinuses that form between the layers of the dura mater, and they drain blood from the brain to the internal jugular vein. And so you can see a lot of these major vessels here. This is a sagittal section, and this is an inferior section of the brain, basically looking from the spinal cord aspect up towards the top of the brain. And so you can see a lot of these sinuses that drain the deoxygenated blood from the brain. There's the corpus callosum. Remember that that's the major tract of white matter that connects the right and the left cerebral hemispheres. And you can see here the great cerebral vein, the straight sinus. This is the confluence of sinuses where the straight and the transverse sinuses meet, along with the sigmoid sinus, and these drain into the internal jugular, and this brings blood back to the superior vena cava and back to the heart. If you look at the underside of the brain, you can see the confluence of sinuses here. There's your transverse sinus, there's your straight sinus, and your sigmoid sinus. And then you can see the superficial middle cerebral vein. You've got one on either side. These are paired, okay? Remember, again, that when you're looking at a lot of these pictures, you want to keep in mind that there is a superficial side and a deep side to a lot of these diagrams. And the superficial side, in this case, is the right side of this picture, and the deep side is the left. Okay, so you can see here the cavernous sinus and the superficial ophthalmic vein right there that drains blood from the eye. Okay, other major vessels. The internal jugular vein receives most of the blood from the brain. It branches of the external jugular vein drain the external structures of the head, and the upper limb is drained by the subclavian vein. And so here you can see the external and internal jugulars, the vertebral vein, the occipital, temporal veins as well. They have their counterparts in the arterial circulation, the axillary vein, the brachiocephalic vein, subclavian, the superior thyroid vein, the facial vein, and the superior ophthalmic vein. So it's not a mystery that a lot of these follow a lot of the same general routes as the arteries do. Now, an interesting thing about the cervical region is that if you look at it, you see a lot of major vessels that flow to and from the brain. Okay, we can see here the jugular vein, and if you look back at the arterial circulation, you can recall the carotid arteries. Now, these are very important vessels, and as a result, they're vulnerable. I don't know if you've ever been chased by a dog, or if you've seen something chased by a dog, but if you think about the way a dog or a pack of dogs hunts, it's a very clever way to bring down a prey item. They pursue the running prey item, be it a man or be it a deer or be it a gazelle. They nip at its heels. Now you might think, well, why are they nipping at its heels? What they're attempting to do is to sever the Achilles tendon, which attaches the soleus and the gastrocnemius to the calcaneus. This is your toe pointer muscle. And what that does, once it's severed, is it brings that prey item down. They can no longer move, as they can't put any pressure on the toe to run. And then the next thing they do is they go for the throat. When they do, they slash open the jugular vein and the carotid artery. And what does that do? Well, that drains blood from the brain. And so you have coma and death in seconds, and then you have lunch. All right, so think about that the next time you watch one of those nature shows, right? Wild Kingdom or some such. Here you can see the arteries of the thorax. The thoracic aorta supplies the viscera and the body wall. It's made up of the bronchial, esophageal, and mediastinal branches, and the posterior intercostal and phrenic arteries. The internal thoracic, anterior intercostal, and pericardiophrenec come from the subclavian artery. You can see all these here. If you refer to your book, figure 20.27, you can see these in a little bit more detail, but notice a few things about these vessels. Okay, there's your aortic arch, and as we drop down, you can see coming off the thoracic aorta these little vessels here. Okay, these are posterior intercostal arteries, and they run between the ribs, and so they supply the intercostal muscles, among other things, and they wrap basically around the back and up to the front of the thoracic cage. These are the esophageal arteries, all right, so they supply the esophagus, which is the tube that connects the pharynx to the stomach. And then you can see the anterior intercostal arteries on the right side. There's the subscapular artery, and you can probably guess what that runs under. Runs under the scapula, all right. Other arteries, the vertebral artery and the internal thoracic artery. It runs along the back of the chest wall inside the bony thorax. Okay, some other arteries of the abdominal pelvic region. So we're under the diaphragm here. There's your diaphragm. You can see the inferior phrenic artery, and this supplies blood to the diaphragm. So it's got one on each side. And then you can see the suprarenal arteries. Suprarenal, you could also call them the adrenal arteries, and so they supply the adrenal glands. The renal arteries lie below them. The superior mesenteric artery breaks just superior to either of the renal arteries and supplies the mesentery that holds the alimentary tract in place in the abdominal pelvic cavity. The lumbar arteries shown here, the gonadal arteries, all right, which in the male go to the testes and the female go to the ovaries. The inferior mesenteric artery, which supplies the mesentery that holds the lower GI in place. The common iliac artery, and as you can see, this breaks down and supplies the lower extremities, and it branches into the internal iliac and the external iliac arteries. Eventually it's going to become the femoral artery as we drop down into the lower extremities as well. This is the sacral artery right here. Okay, the branches of the celiac trunk supply the upper abdominal viscera. This includes the stomach, the spleen, the liver, and the pancreas, and you can see where each of these branches comes off the abdominal aorta and which organs they supply. And so it's a nice little tripartite branch, okay, the celiac trunk. Very important landmark here. Remember that the renal and suprarenal arteries lie very nearby, the renal just below and the suprarenal basically lateral to this. And here you can see the gastric arteries, the splenic artery, which, supplies the spleen, and the left gastro omental artery. Okay, this is the greater omentum. And so, I'm sorry, not the greater omentum, this is the lesser omentum. And my mistake. This is the greater omentum. The greater omentum hangs like an apron in front of the small and large intestine, and it's supplied by this artery. Another name for the greater omentum is your beer gut. The lesser curvature of the stomach is held to the liver by the lesser omentum, and it also is supplied by the left gastric artery and the right gastric artery branches that come off of there as well. And so here you can see the mesenteric arteries and what they supply. So you can see here the inferiopancreoduodenal artery, right, supplying the pancreas and the duodenum. You can see the middle colic artery, which supplies the transverse colon. Superior mesenteric artery down here. The right colic artery. The jejunal arteries, okay, that supply the jejunum. The ileal arteries that supply the ileum, the middle portion of the small intestine. And you can see here, what else? That's basically it. And then if we look at the transverse and descending colon, you can pick up here again the abdominal aorta. Here is the inferior mesenteric artery branching off into the left colic artery, the sigmoid arterioles and the suprarectal artery, and then finally we have blood supply here to the rectum and the anus. Okay, veins of the abdominal and pelvic region, very similar to the arteries of the abdominal pelvic region. Again, you've got suprarenal and renal arteries where they're expected. You've also got the inferior vena cava right here, okay, and these are the hepatic venules. Okay, so these run to the liver, drain the liver. There's the inferior phrenic artery on either side. It drains blood from the diaphragm. There's the left and right suprarenal arteries, the left and right renal arteries, and you can see here the lumbar venules, okay, the left ascending lumbar vein, the right ascending lumbar vein, the iliolumbar vein. There's the gonadal veins, the median sacral vein down here, and these are the internal iliac veins that drain blood from the lower extremities. Internal iliac here and here, external iliac here and here. Okay, the veins of the abdominal pelvic region drain nutrient-rich blood from the viscera, these being the stomach, the spleen, and the intestines, and then to the liver so that blood sugar levels are maintained. And the idea here is that the liver acts essentially as the body's kitchen. So what it does is it takes the goodies that come from the GI and decides whether it's going to store them for future use as fat or glycogen, or if it's going to mobilize the fat or glycogen stores, put them into the blood so that we can supply nutrients to the body's tissues, all depending on the body's metabolic needs at the time. Here you can see the arteries of the upper limb. The subclavian passes between the clavicle and the first rib. The vessel changes names as it passes through different regions. The subclavian becomes the axillary vein as it runs under the arm, and then it becomes the brachial vein in the upper arm. It then branches into the radial and ulnar veins, and those run obviously near the radius. Remember, that's thumb side of the forearm, and the ulna, which is the little finger side. And here you can see the veins of the upper limb, and they essentially mirror the arteries of the upper limb pretty much. You can see the axillary and brachial veins, the radial and ulnar veins as well. There are the palmar arches, superficial and deep palmar arches. And here you can see the arteries that supply the lower limb. They branch from the external iliac. This branches off the common iliac, and then it becomes the femoral, then the popliteal, and then the tibial, okay, as we move from the pelvic region down into the lower limbs. And the veins of the lower limb essentially mirror this, so you can see, with a few exceptions, there is the circumflex femoral vein, right? Again, the reason it's called circumflex, it has a circular anatomy. These are the deep femoral veins here and here. There's the femoral vein. There's the greater saphenous vein that runs across the front of the knee. the popliteal vein that runs behind it. There's the small saphenous and the anterior tibial and the fibular running next to the fibula. Okay, the deep veins here are shown in dark purple. The superficial veins are shown in light blue. Okay, we talked about the fact that there are pressure points. This is where we like to take a pulse so we can see what your heart rate is using a formula that allows us to correct for between pulse rate and heart rate. Some of the major arteries close to the surface allow for palpation of the pulse, and they serve as pressure points to reduce arterial bleeding. We also want to talk about hypertension, the most common cardiovascular disease that affects about 30% of Americans over the age of 30. It's termed the silent killer. It's a major cause of heart failure, stroke, and kidney failure. Primary hypertension is essentially an increase in the pressure inside the vessels, and it's primarily due to problems with regulation of hormones that control blood pressure. Secondary hypertension is generally secondary to another disease. We can talk a little bit more about primary and secondary hypertension. The bottom line is the reason it's such an insidious disorder is that the delicate vessels, the capillaries, if they're under increased pressure for an extended period of time, run the risk of bursting. And if they burst, it can cause a stroke in the brain, or it can cause a myocardial infarction that happens in the heart. And so hypertension isn't something that you want the body to have to endure for an extended period of time. Okay, I'll see everybody in class, and have a good night.